We're off traveling the Oregon Trail in this sketch as we explore acute diverticulitis. So, grab your oxen and stock your wagons with some provisions, because you're about to experience some acute and diverting action. Let's get started. Diverticulitis is inflammation and infection of the colon due to microperforation of diverticula. Recall that diverticula are those little outpouchings of colon mucosa formed by increased pressure in the colon, represented by these two burlap sacks hanging off this colon-esque pinkish wagon. One has teensy tiny holes and is spilling its contents to represent the microperforation, and the one on fire should no doubt remind you of the significant inflammation that results. Risk factors that contribute to diverticular formation include chronic constipation, hence why our driver is using this plunger, our recurring symbol for constipation, as a riding crop, and a low-fiber, high-fat diet, shown here by this falling wheatgrass and those tubs of butter and lard being transported. All that fat must be in high demand in the Wild West. Other risk factors include older age, sedentary lifestyle, heavy meat consumption, obesity, and, as with everything, smoking. Whoa there, Nellie. Looks like this bandit's trying to make off with that precious golden butter cargo. We better, divert the wagon off the trail to try and get away. His flame bandana and the location of his punch on the poor wagoneer should remind you that the classic presentation of acute diverticulitis is fever from the inflammation and infection, and left lower quadrant abdominal pain and tenderness. The left lower quadrant is most common because the majority of diverticulitis happens in the sigmoid colon, where most diverticula form. Nausea, vomiting, and anorexia, or not wanting to eat, are also common, hence our poor driver now projectile vomiting from the pain. Couldn't the bandit have just chosen a better time to ambush him and not right after lunch? So inconsiderate. That attack must have given this poor ox a case of dysentery. Just look at that streaming diarrhea to remember that patients typically have changes in their bowel habits as well. Constipation, or even an ileus from all that inflammation, is more common, but patients can also present with diarrhea. Wait, wasn't it the player that was supposed to get dysentery? And to finish off clinical presentation, looks like our fierce bronco here has gotten a little, pissy from all that excitement. A small portion of patients can actually have urinary symptoms, like urinary frequency, urgency, dysuria, and on UA, sterile pyuria. This is due to the colonic inflammation irritating the nearby bladder. Dang, these animals are full of all kinds of fluids. Next, on to diagnostic steps before it starts to get slippery from all the fluids. On labs, the inflammation and infection is reflected by leukocytosis. So, we've got our classic white birds flying high and away from all this commotion. Other labs may show electrolyte disturbances and dehydration because their bowels are all upset and not absorbing properly, and fluid losses are probably not being replaced adequately. So, leukocytosis and the classic clinical presentation should give you a good idea of the diagnosis, but acute diverticulitis is confirmed with a CT scan of the abdomen and pelvis, with both PO and IV contrast. So, we've got our very brave CT black cat with its yin-yang collar, representing contrast, and it's drinking white milk to especially call out the oral or PO contrast. Abdominal x-ray may show generalized inflammation and maybe air fluid levels if there's an ileus, a phlegmon, or a fluid collection, but it's much less sensitive and less specific than CT. Finally, don't get dragged into the trap of ordering colonoscopy. With active inflammation, scope in the bowel can cause perforation, which is really bad. So wait till the inflammation is over. More on that later. But who's driving this wagon if it's not the cat? Ah, it's the sheriff and deputy on their way to save our lard-toting wagon, because the people need their buttermilk biscuits. But also to give us the first step in management of these patients. The clearly overworked, or underworked, deputy taking a snooze, and our sheriff's lasso of ivy should respectively remind you to put the patient on bowel rest, meaning NPO, and start them on IV fluids to resuscitate and replace fluids from third spacing and the GI losses. Of course, we got to deal with the actual infection, so uncork those antibiotics. We need to cover gram-negatives and anaerobics, so typically metronidazole and ciprofloxacin are used, or another fluoroquinolone. So we've got our recurring metro train sign for metronidazole, and the flowers at the base of the sign for fluoroquinolones. Once the infection is taken care of, the microperforation will usually seal up on its own. Certain patients can be managed as outpatients, as long as they're not nauseated and vomiting or in severe pain, and are able to take their antibiotics and keep themselves hydrated. You may be saying, hey, wait, I thought we just made them NPO. If they can hold down food and eating doesn't worsen their pain, these patients can probably go home on an easily digestible diet and follow up later in the office. But for those patients who present with severe symptoms or lab findings and need IV fluids and IV antibiotics, and those at increased risk of complications, like the elderly or immunocompromised, inpatient admission is necessary, like this elderly prisoner who has checked in to the prison wagon. Once they're feeling better, tolerating PO, and their symptoms are under control, they can often be discharged. Uh-oh. Looks like this isn't the first wagon that the bandits hit. Meaning this wild sketch isn't over just yet. 75% of patients have uncomplicated diverticulitis and will heal properly with everything we've just said. But that leaves a quarter with complicated diverticulitis, which usually stems from significant inflammation. Those patients will require both inpatient admission and probably some procedural interventions. The most common complication is an abscess, as the body tries to wall off the inflammation and microperforation, symbolized by this bright red, bulging sack of red hot chili peppers to really hammer home the idea. The abscess can either be right next to the inflamed colon segment or in distant parts of the abdomen, like around the liver or small bowel. But they're all treated the same way. Since an abscess won't heal with antibiotics alone, they need to be drained, and any abscess over 3 centimeters in diameter should undergo CT-guided drainage. Anything smaller than that usually goes away on its own. And though it's rare, persistent or recurrent abscesses will need surgery. Another complication is frank perforation. This is different from the microperforation we've been talking about. Just compare the big ol' hole in this wagon with all its contents falling out to the microperforation in the burlap sack we talked about earlier. The patient typically experiences severe pain once a frank perforation occurs, followed by temporary relief due to the release of pressure, and then the development of peritonitis over several hours, since the stool is leaking out into the abdomen. Immediate resection and washout is necessary. And as a side note, abscesses and perforations are described with the Hinchey classification. We're not going to get into those details here, but just note that this classification system exists. A large bowel obstruction can also occur, like this large obstructing boulder. If that boulder wasn't there, maybe this wagon could have escaped. An obstruction can result from significant inflammation or compression from an abscess. Recurrent diverticulitis can also cause scar tissue and stricturing over time. If the obstruction is persistent, even after antibiotics and drainage of any abscesses, or is due to a chronic stricture, surgery may be necessary. Now, with all this inflammation, the colon wall can actually fistulize, meaning a connection forming between 2 epithelialized surfaces to nearby organs like the bladder. Just look at this leaking fluid that's connected to the bladder-shaped puddle. Is that transmission fluid? This colon to bladder connection is called a colovesical fistula, and patients present with pneumaturia or fecal uria, and often have recurrent UTIs. Rarely, the rectum may fistulize to the vagina, called a rectovaginal fistula. Surgery is necessary to remove the fistula, usually after acute illness is over. Mount Hood is on the horizon, so to finish up, we have to be sure to follow up with these patients. Just like we're following this gentleman over here who's using the Metro and scoping out the caves with a flashlight, our symbol for a colonoscopy. A colonoscopy is necessary once the acute inflammatory episode is over. Recall that we don't ever scope an inflamed bowel. In order to both confirm the diagnosis by seeing diverticula in the colon and to rule out malignancy, which can sometimes present similarly. Our man also seems to be making a large delivery of fibrous wheatgrass, which of course is a reminder that patients should be counseled to stay on a high fiber diet to prevent recurrences. If it was a recurrent episode, it's time to discuss surgery with your patient, since multiple recurrent episodes may make it more likely that it will recur again, and thus are an indication for resection. So, the bandit's been caught, the wagoneer kept his barrels of fat, and the sheriff saved the day. And with that, we're out of here. Let's review. Acute diverticulitis results from the inflammation of diverticula due to microperforations. Risk factors include chronic constipation and high-fat, low-fiber diets, among others. The classic presentation is fever and left lower quadrant abdominal pain and tenderness, with nausea and vomiting and often anorexia. Changes in bowel habits are also common, like constipation, ileus from the inflammation, or diarrhea, and urinary symptoms from inflammation irritating the bladder may also occur. Workup includes labs, which would show leukocytosis, and CT abdomen and pelvis with IV and PO contrast, which would show inflammation around the affected segment of the bowel, and may show evidence of additional complications. Initial management for uncomplicated diverticulitis begins with bowel rest, IV fluid resuscitation, and IV antibiotics. Patients able to tolerate a PO diet without increased pain and that can keep themselves hydrated may be candidates for outpatient management with close follow-up. But patients with significant pain, nausea and vomiting, high fevers, significant leukocytosis or metabolic derangements, or those who are elderly or immunocompromised should be managed as inpatients. Complicated diverticulitis occurs in about 25% of patients due to the inflammation causing certain complications, including abscesses, perforation, obstruction, or fistulization. Abscesses should be drained, while the others typically require surgery. Multiple recurrences may also require surgical resection. Follow-up after the acute period is necessary. Colonoscopy should be performed once the inflammation has subsided to confirm the presence of diverticula and to rule out malignancy. Patients should be counseled to stay on a high-fiber diet to prevent recurrence as well. Maybe next time the wagoneer should take the metro, like our wheatgrass delivery man. Not just less ambushes, but a little less poop and pee cleanup, if you know what I mean.